Good morning, everybody, and thank you for tuning in for our discussion of pleural effusions, which I will cover via case-based review. I have no disclosures, and my outline will include quickly normal anatomy and function, how pleural fluid accumulates, our best method for evaluating pleural effusions, diagnosis and management of common exudates, and evaluating the common entity of exudative unclear etiology. So our pleural fluid is very, very small. Our pleural space is a barrier between the parietal pleura along the ribs and the visceral pleura attached to the lungs, and normally has no more than a couple milliliters of fluid. And the absorptive capacity is quite enormous. So when pleural fluid accumulates, production and reabsorption of pleural fluid has gone quite awry. I'm going to jump right into an interesting first case to sort of wake everybody up. It's a bit atypical. It's a 67-year-old man with dyspnea and cough for 2 months, has poor chest excursion on the right. Ultrasound of the right chest reveals a small pleural effusion. And on chest x-ray, lung markings are present here. So this is not a tension pneumothorax. There's lung expanded here, yet the trachea is shifted towards the right of the pleural effusion. And the pleural effusion is sampled, revealing a protein of 3.9, an LDH of 200, making it a transudate or borderline exudate. Glucose is 98, pH 7.48, and all the cultures and cytology are negative. So the next step in managing this patient's pleural effusion would include perform a large volume thoracentesis, place an indwelling pleural catheter, do a thoracoscopy with biopsy, perform a bronchoscopy or B&D. And I see people voting for perform a bronchoscopy. And I stop the. Okay, great. So lots of folks are leaning towards D, which is actually the correct answer, perform a bronchoscopy. And that's because the fluid, the trachea was shifted towards the side of the pleural effusion, and the pleural effusion was small. And this is actually a trapped lung from an endobronchial mass, preventing expansion of the right lung. And when the lung cannot expand, there is a negative pleural pressure created on each inhalation, quite strong negative pleural pressure, which draws hydrostatic fluid in. And if we look at trapped lung physiology, if we were to drain pleural fluid out in a normal lung, shown here, the lung reinflates and expands to the negative pressure as pleural fluid leaves. But in a trapped lung or partially trapped lung, shown in the middle, every time you remove any fluid, there's a strong negative pleural pressure generated. So this is transudative pleural fluid accumulating in the context of a trapped lung, and that's why bronchoscopy was indicated. So other more common causes of transudate, of course, include fluid overload states such as congestive heart failure, cirrhosis or nephrotic syndrome, trapped lung we just reviewed, which can also be exudative if it's due to malignancy or an inflammatory entrapment process. Pulmonary embolism through infarction can be exudative or transudative. Myxedema, urinothorax, and CSF leak. Exudative effusions are almost predominantly due to infection such as parapneumonic or empyema, malignancy or pulmonary embolism with infarction, but a whole host of inflammatory, malignant, and infectious causes, as shown on this slide, can cause exudative effusions, and the list is quite long. The diagnostic evaluation of a pleural effusion, although we focus on pleural fluid analysis, and I certainly want to encourage pleural fluid analysis, is a comprehensive approach that takes into account the clinical information on the patient, as well as associated radiographic findings, such as infiltrate, mass, or lymphadenopathy, nicely demonstrated in our endobronchial mass or endobronchial occlusion trapped lung case. We should err on the side of tapping pleural effusions if it is safe procedurally. And if the effusion is tiny, or less than 10 millimeters on a lateral decubitus film, then observation is reasonable. If heart failure is not present and the pleural effusion is greater than that, then a thoracentesis should be performed. And certainly if heart failure is present and there's fever or asymmetry or pain, a thoracentesis is performed. Otherwise, observation under diuresis is reasonable unless the pleural effusion persists despite the patient reaching euvolemia and effective diuresis. I want to remind folks that a PA and lateral film is important for evaluating a pleural effusion, as up to 500 milliliters of fluid can be hidden behind the diaphragmatic leaflet posteriorly, which can be seen in a lateral film or a decubitus film or X-ray or CT. We often are instructed that 1 liter of pleural fluid should be removed and no more due to the risk of re-expansion pulmonary edema. However, data has accumulated on the rate of re-expansion pulmonary edema in the context of larger volume thoracentesis. And this is a seminal study of 185 patients where the hemithorax was drained dry from anywhere from 1 liter to 3.5 liters being removed. And only one patient, 0.5%, had symptomatic re-expansion pulmonary edema. That patient had 1.4 liters removed. 4 patients total, 2.2%, had radiographic re-expansion pulmonary edema without symptoms. And re-expansion pulmonary edema did not correlate with pleural fluid volume, end expiratory pleural pressure, or symptoms during the procedure, indicating that transudative pressure changes are by themselves not accounting for re-expansion pulmonary edema. So there are no clear guidelines, but re-expansion pulmonary edema is rare, and strict adherence to limiting a thoracentesis to 1 liter is not supported by the data. Personally, in my experience, if a pleural effusion is free-flowing, there's no resistance, and the patient is not in decompensated heart failure at the time, every attempt should be made to complete the thoracentesis until the hemithorax is dry, and only use caution if the patient is in obvious or decompensated congestive heart failure. When analyzing the pleural fluid, we appropriately focus on LDH, total protein, or the Lights criteria using these ratios. I want to point out, however, in the next slide, that the serum to pleural fluid albumin gradient, similar that we would use for ascites or the serum albumin gradient or the SAG, of greater than 1.2 grams per deciliter is also a very important metric to define a transudate. In fact, if we look at this table, for sensitivity and specificity of an exudate by Lights criteria, we find that Lights criteria is very sensitive at detecting pleural exudates, but not specific. So up to 15 to 18% of all exudates identified by Lights criteria turn out ultimately on follow-up to be transudative processes. Whereas the serum to pleural fluid albumin gradient is more specific for a transudate, but a little less sensitive for identifying exudates. So if a patient has a borderline exudate, uncomplicated appearing exudate by Lights criteria, and the serum to pleural fluid albumin gradient is less than 1.2, then a definition of a transudate is reasonable to reach. This next case is a 37-year-old woman with 2 months of dry cough, dyspnea on exertion, and right anterior pleural chest pain. Her thoracentesis revealed a frankly bloody pleural effusion with an hematocrit on the fluid of 22%. So this is a grossly bloody pleural effusion. And if we follow the hematocrit of the fluid, a hematocrit of less than 1% is not significant. 1 to 20% is a hemorrhagic process, such as malignancy, pulmonary embolism with infarction, trauma, empyema with hemorrhage. 20 to 50% of the circulating hematocrit, or greater than 50% of the circulating hematocrit, is almost by definition a frank hemothorax or frank hemorrhage in the pleural space. If we follow this algorithm, it gives us a list of common causes of frankly bloody pleural effusions. And if there's no trauma or procedures and the peripheral hematocrit is less than 50%, we think of lung cancer, pulmonary embolism with infarction, tuberculosis, hemorrhagic empyema, uremia, coagulopathy. If the pleural fluid hematocrit is greater than 50%, that's a frank hemothorax. Those patients should have emergent evaluation, including a CT angiogram or angiography to identify a vascular anomaly, such as an AVM of the intercostal arteries or internal mammary arteries, or a highly vascular tumor, such as neurofibromatosis. Non-vascular processes, but vascular-rich lesions include endometriosis, pleural metastases, thymic cysts, and occasionally just osteophytes along the chest wall, the paravertebral or sternal, what we call exostoses, as shown in this CT scan, where we see osteophytes off the vertebrae, osteophytes off the sternum. And you can imagine if it's an elderly person in particular on potentially antiplatelet therapy, anticoagulation, with fragile vessels, vigorous coughing might trigger spontaneous hemorrhage, but these lesions are a diagnosis of exclusion as a cause of hemothorax, as they are quite commonly found on CT scans. This patient underwent pleuroscopy and VATS, which was appropriate, and was identified as having thoracic endometriosis syndrome. She, in addition to mechanical pleural disease after her VATS, underwent hormonal suppression therapy and did very well. This is a 72-year-old man with 2 days of right-sided chest pain, dry cough, chills and dyspnea, febrile with a leukocytosis, and a moderate free-flowing pleural effusion. Blood cultures were obtained and antibiotics started. This is a case of highly suspicious infection or parapneumatic effusion. Thoracentesis was done urgently, which is appropriate, and revealed an exudate with a high LDH and a pH of 7.18. Gram state and cultures were negative. So a question, the most likely infecting organism is, and I think I jumped ahead and I apologize to the answer. Yeah. Great. Well, I see everybody's picking very, very reasonable answers, including strep pneumo and strep milleri. The answer is actually strep milleri. And the reason is, if you look at community-acquired empyema, 32% are actually these intermediate strep. Absolutely, strep milleri is not a common cause of pneumonia, and strep pneumonia, Haemophilus influenza, Moraxella, those are common causes of community-acquired pneumonia and absolutely can be complicated by parapneumonic effusion empyema. But primary empyema, cases without a lot of pneumonic symptoms, are often due to intermediate strep, and that's why this case was due to strep milleri or intermediate strep. The next step in managing this effusion is antibiotics and close observation, thoracentesis to drain the pleural space, VATS decortication, chest tube drainage with or without fibrinolytics to the pleural space, A or D. Great. I think most people are identifying the idea that this is a potentially scary and complicated parapneumonic pleural effusion or empyema, and that definitive chest tube drainage is important. So the answer is D, chest tube drainage with or without fibrinolytics. And why do we have to drain this effusion? Because we worry about complications such as chronic pleural infection, secondary lung abscess, empyema necessitans, which is a pleurocutaneous fistula, or mechanical complications such as lung entrapment and fibrothorax. And who needs to be drained, and why does this patient need to be definitively drained? Well, certainly if the pleural effusion had been small, the risk of one of these poor outcomes was low, so no drainage is needed. If the effusion is less than half the hemithorax and sampled, and the gram stain and culture are negative, and the pH is greater than 7.2, the risk of one of these concerning outcomes is low, but the effusion needs to be followed closely to resolution as well as other clinical symptoms. If the pleural effusion is greater than half the hemithorax, or loculated, or has thickened pleura, or the gram stain or culture are positive, or the pH is less than 7.2, which it was in this case, then the risk of one of these complications is high, and the effusion needs to be drained entirely and kept drained until the patient has resolution of their infectious process. There are many definitive pleural drainage strategies, most commonly done via now smaller bore chest tubes placed by interventional radiology or interventional pulmonology. The use of fibrinolytics to promote drainage and break up any loculations has been studied in several trials. The first intrapleural streptokinase trial was equivocal, but in 2011, there was a trial of pleural saline or TPA, tissue plasma antigen activator, or DNase, or a combination of TPA and DNase given twice daily for 3 days through the chest tube. And the DNA and TPA group had decreased need for surgical intervention, 4% versus 39%, and an improved radiograph and clinical outcome at day 7 and day 30, as shown in these chest x-rays, where we have resolution of a fairly complicated parapneumonic pleural effusion using chest tubes and fibrinolytics and DNAs. We do have to understand that this chemical treatment leads to pleural hemorrhage in about 1.8% of patients, which can be serious, as bleeding in the pleural space can lead to significant blood loss if not controlled. And it markedly stimulates pleural fluid production up to 6-fold, which can lead to some discomfort and loss of fluid, which is partly how it works, by lysing loculations. And it is contraindicated if there's any evidence of a breakdown of the alveolar lining, such as a bronchopleural fistula or spontaneous air leak, as this treatment can perpetuate bronchopleural fistula. Surgical decortication is ultimately required in about 30% of cases, but pleuroscopy can be done in the majority of them. And antibiotics should be continued until all the drains are out and the pleural fluid production has stopped, generally a minimum of 2 weeks, but sometimes several weeks of therapy can be indicated if there is complicated pleural fluid collections, prolonged drains in place, or unusual organisms such as actinomyces. This next case is a 53-year-old man with hypertension, atrial fibrillation, 2 months of acute on chronic exertional dyspnea and pretibial edema. He has orthopnea and paroxysmal nocturnal dyspnea, seemingly heart failure with a large right-sided pleural effusion. Well, a thoracentesis revealed a very milky lipemic fluid with triglycerides over 1,200. So this certainly seems like a chylothorax, and we often use our triglycerides as greater than 110 to define a chylothorax, less than 50 as a negative chylothorax, and in between requires lipoprotein analysis. Chylomicron analysis can take several days to even a week to come back, but if chylomicrons are present, this is a chylothorax. Traumatic causes of chylothorax include chest trauma and thoracic surgery. Non-traumatic causes include infiltrative tumors and granulomatous inflammatory processes such as lymphoma, histoplasmosis, TB, sarcoid. Chylosociety can also migrate across the diaphragm, causing a chyloform pleural effusion. Chronic obstruction of the left subclavian vein can also cause stasis in the thoracic duct, including LAM and left subclavian DVT. Pseudochylothorax is a lipemic appearing pleural effusion that is not containing chylomicrons, but due to chronic cellular breakdown from a chronic exudate. And that represents cell membrane breakdown, which is very low in triglyceride, very high in cholesterol and phospholipids. So if the cholesterol is high and the triglycerides are low, this is generally a pseudochylothorax due to a chronic exudate with cellular breakdown. If the triglycerides are high, but the cholesterol is low, and of course, there's confirmatory chylomicrons, this is consistent with a true thoracic duct leak and a chylothorax. Chyle loss is associated with high mortality due to malnutrition and loss of fat-soluble vitamins, loss of immunoglobulins and lymphocytes leading to immune suppression, and the mortality is quite high from an untreated chronic chylothorax. Management includes decreasing chyle production by ingesting medium-chain triglycerides, removing the chyle with several types of shunting or pleural-based procedures, or trying to close the chyle leak with duct embolization, which our patient ultimately underwent. I want to start wrapping up by reviewing the important topic of an exudative effusion of unclear etiology. It's a 46-year-old man with a history of myelodysplastic syndrome, had an unrelated allogeneic stem cell transplant complicated by cutaneous and GI graft versus host disease. He has dyspnea and progressive right-sided pleural chest pain for 3 weeks, no fever, chills, or sick contacts. Medications include immunosuppressants, prednisone, and tacrolimus. He's on atovaquone and Valgate cyclovir. Chest x-ray shows a large right-sided pleural effusion, which on thoracentesis was clearly exudative with a near equivalent serum and fluid LDH and high albumin, but a reassuring pH and glucose, and an adenosine deaminase that was negative, indicating tuberculosis is probably not present. Cultures were in fact negative for typical and atypical microbes. Cytology and flow cytology were negative for malignancy. So in a case like this, perhaps in a different scenario with a less vulnerable host, 20% of exudative pleural effusions have no clear etiology despite pleural fluid analysis, imaging, and even thoracoscopy and pleural biopsy. Followed longitudinally, most of these pleural effusions end up being malignancy, including mesothelioma or atypical lymphoproliferative disorders, chronic empyema due to atypical organisms, tuberculosis pleural effusions, RA, or just simply diuresed heart failure. And an algorithm for approaching a patient like this is first to be sure that the patient does not meet criteria for heart failure. If they don't, then a careful history, microbiology, and cytology should be performed. PE should be considered with an ADA and interferon gamma level, and if negative, consider thoracoscopy and pleural biopsy. We have many molecular and antibody tools at our disposal now to identify specific tumor markers, allowing us to identify pleural metastases and primary lung cancers, as shown in this slide. This patient had a whole host of negative infectious serologies, as shown here, and ultimately a pleural biopsy that showed a positive silver stain and a positive modified AFB, and this was in fact pleural nocardia. Patient received prolonged treatment with Bactrim and did extremely well. I'm going to end with a bonus case just to review in a couple slides an important topic. This is a 55-year-old man with subacute dyspnea, a history of alcohol use disorder, and decreased right breath sounds and ascites on exam with a very large right-sided pleural effusion. And in contrast to our first trapped lung case, the trachea is almost deviated away from the side of the pleural effusion, indicating some tension under the fluid. So the etiology of this patient's right-sided pleural effusion is almost certainly an hepatic hydrothorax, which was confirmed on thoracentesis. Hepatic hydrothorax occurs in about 5 to 10% of patients with ascites. It's usually a large effusion on the right side due to more frequent rents in the diaphragm or rifts in the diaphragm on the right side. Pleural fluid can accumulate rapidly and even under tension due to the sumping action of our breathing. So when we breathe in, negative intrathoracic pressure is generated, which draws ascites into the hemithorax. And if there's any one-way valve effect, you can effectively sump ascites into the right chest or into the left chest under pressure and build up a tension hepatic hydrothorax. As a result of this, 20% of hepatic hydrothorax patients cannot have evident ascites. The pleural effusion should be tapped diagnostically and also to rule out spontaneous bacterial pleuritis, just like you would bacterial peritonitis. And if there is an uncomplicated infected fluid, this is one of the rare instances where pleural fluid could be treated as spontaneous bacterial peritonitis is with antibiotics alone, following closely without definitive pleural drainage. The treatment is for managing the underlying ascites and cirrhosis, which is often difficult, and a transjugular intrahepatic portosystemic shunt can be effective for refractory hepatic hydrothorax. This patient was treated initially very aggressively with spironolactone, furosemide, IV albumin, and octreotide to try to minimize portal pressures. It was ultimately ineffective, and he underwent TIPS and had a remarkable radiographic result, as shown by a chest X-ray 3 months later. Well, thank you for your attention, and we look forward to the question and answer period later.
Scott, can you take a couple of questions now, do you think?
Absolutely, yes.
That'd be terrific. I thought your presentation was very comprehensive and actually addressed a number of the questions that were submitted as you were going along. One of the ones that came in had to do with connective tissue disorder like rheumatoid arthritis. Do you ever see a hemorrhagic effusion in that context?
I have seen one or two. The exudative effusions in autoimmune diseases are highly inflammatory, particularly in RA and even in lupus, as evidenced by their low glucose and often very high LDHs. And if a person has antiplatelet therapy or anticoagulation as part of their medical regimen, it wouldn't be surprising if that inflammatory reaction led to some hemorrhage of fragile surface vessels, which I think in the few cases I've seen where there is more significant bleeding, it was in that context. Just as we can see hemorrhagic empyemas, where the bacterial or atypical infection can lead to fragility of the surface vessels on the pleura can lead to hemorrhage. I would think the same mechanism could occur in autoimmune disease, but it's not a common entity.
Gotcha. Here's one I wouldn't ask anyone else but you about filariasis.
Yeah.
It's a cause of, can that cause a chylothorax or pseudocylothorax?
Yes,
And,
it could cause it.
Go ahead.
Oh, sorry. Go
Go
ahead.
ahead. And I was going to ask the same about pancreatitis and its association with chylothorax.
Right. So filariasis absolutely can cause a chylothorax, mostly because the filaria can obstruct the thoracic duct and or the venous system. And so it absolutely can cause sort of a congestive chylothorax. And that is definitely on the list of causes of chylothorax. And in pancreatitis, there is a high triglyceride, there could be a very high triglyceride count in a chronic pancreatic effusion or exudate. I think there, one of the key distinguishing features, if it's truly an effusion secondary to pancreatitis, would be the amylase being extremely high. And that would be an important metric to rule out whether there's any fistula that's accounting for the triglyceride-rich pleural effusion.
Terrific. And one quickie before we let you go, do you send all pleural effusions for cytology?
I think practically speaking, we usually do, because we rarely know at the time of fluid collection whether we're going to find a definitive transidate, a possible exudate, or somewhere in between. As we said, 15 to 18% of exudates by Light's criteria end up being transidates, but it's very hard to parse out that sizable percentage. So we have this uncertainty whether a transidate or exudate's truly a transidate or exudate. So I think when you're sitting there with the fluid literally in front of you and you're trying to decide whether to save it or analyze it, you'd hate to lose the opportunity. So I think practically speaking, most of the time a cytology sample is sent. If you knew that the fluid was going to be transidative, you have a good history with the fluid and the patient, maybe it's not high yield. I would say we often send these large volumes of pleural fluid to the lab for cytology analysis, 1.5 liters. We're very proud to send that whole bag down. Most cytopathologists will now tell us, 10, 20 cc's has usually enough cellular pellet to give an answer. They're happy to take the whole lot, but it sometimes can be a little easier and less daunting than sending the whole bag down.
Terrific. Thank you very much. I think we'll let you go. The last one was not a question, it was a comment. Said, excellent and very thorough. I look forward to going through this again. Nice job.
Okay, great. Yes. Thank you.